specialists who they're programmed to fix the bite and in a quasi bite fixation, and they changes the whole neurosensory feedback. And what happens is somehow they get better. They think they get better, but then again, whole thing starts again. So in their own mind, they're convinced that's the bite, and the bite. Oh, what was wrong? Let me adjust a little bit. And we all know that this is not going to end. So I have a lot of these patients with occlusal hypervigilance in my practice that drives them crazy, that drive me crazy. So it makes life difficult. They need other care, and sometimes other treatments will help them. But because of the first adjustment that caused the problem in the first place, and it did help to alleviate some of the symptoms in a quasi way, it made the whole thing worse. And that's a problem. That's a problem. That's a problem.
All right.
My screen.
Yep. All right, Circus, I'm going to mute myself, so you take the floor, right? Thank you.
Thank you, but I'm happy, Varun, for your input. Okay, be my guest. I might ask you if you every now and then to come in if you don't mind. I'm happy to have you, really.
Sure, no problem, no problem.
Welcome to the ICL, International College of Dental Practitioners College. We run courses, and we have a postgraduate diploma that you all know, and you're most welcome. It's filling up quite fast. We've got a few more spots left. By all means, please try. We also have a one-day seminar on Sunday. We made the Sunday because the interstate guys can fly too. So there's few places left, but that's filling up as well. Actually, it was a short notice, but it's coming out good. We're filling up the places. That will really be good for those of you who want to be a bit more confident in composites to sort of come to the seminar and learn how to deal with tooth fairy patients and a lot of other issues, not just the tooth fairies, how to manage those patients. That's important. But nevertheless, we're going to discuss our patient's female, 35, and she's missing a few teeth. And the endodontist suggested that we got crazed lines, and he feels that this is going to guide the prognosis, which I definitely agree. And also the fact that when the patient's at age 45, she's a professional lawyer, and she's very concerned about this. There's a lot of concern which I'll go with you, and I'm happy to ask you questions and how do we look at this situation, because especially tooth number 36 has got the molar has got a questionable prognosis. Now you can see from the periodontal ligament, this is a loaded, that takes a lot of load because the only single standing tooth there. But there was another tooth here which was replaced. We'll come to that in a minute. But nevertheless, let's look at the clinical situation we have initially. Now here's the initial position of this tooth. You can there's a large composite restoration on this tooth, and what would be my concern here, for instance, when this patient present in our practice, and when you think about it, we have large crazed lines, and these crazed lines you can see over here. So I have a concern. What would my concern be in assessing this patient in that particular area, where I can see a lot of crazed lines here. Just give you some hints. You can see there's a fresh line going around. Can you all hear me well? Yep. And we have a crown here. Okay. I haven't shown you the extra of the crown, but in many ways we need to look at this. So what I'm thinking is that in terms of with this patient, when you do the transillumination, you can see those crazed lines. And so I presume that patient is loading on this tooth. Now, what other concern I have is there's a crown there, that tooth number 35, and tooth number 35 could be loading as well, although it's a porcelain, I think it's a metal ceramic type of crown, or could be a zirconia crown. If it's zirconia, it's probably worse than metal ceramic. But nevertheless, I don't think this tooth is only loading, but also the 35 is loading as well. And again, from looking at the history, the patient has got a history of severe clenching, and when when we look at this patient, I still need to do a risk assessment. Now, why do I need to do risk assessment? And when you think about this, I'm showing you the cone CT of this patient. And if you all know that the aim of the risk assessment is to evaluate any hazards that is present and minimize or remove these hazards in order to be able to reduce the loads that are applied to the existing or future proposed restorations. Because one thing we have to understand that the first law of sanity is if you keep doing the same thing expect to get different results, it's just not going to happen. And we know that if you replace the missing teeth or whatever we do here, I mean, if it requires replacement, in this case it does, and I will justify later, the same forces that cause the failure of the teeth will also act on the new restorations, and that will fail. And then we discussed in Varun early on, Varun, if you want to come into this, that we need to explain to the patient that what we face with, and they need to understand that the risks and associated restorative risks, and they also
Absolutely.
problem. Yeah, go ahead, Varun.
Yeah. I mean, I think that's first of the discussion, because whenever I see a patient with a tooth which is fractured, cracked, or let's say worn dentition, the discussion with the patient is always at the causative factors that have caused it. And if we don't modify that, there's always going to be risk of you doing the same to my restorations, because I'm very clear telling the patients whatever I put on the tooth is not going to be stronger than what your natural tooth was, or is not going to be as forgiving. And if you're capable of doing this to your tooth, you're very capable of doing the same to my future restoration.
Exactly.
And this is
exactly. Also, the fact that many times when the patients are presented to us, we already have a compromised situation. That
correct.
was before. So, they want some sort of long-term solution. Yeah, go ahead. I'm listening.
So, I mean, in situations like this, it's a terminal tooth. If I'm just picking up this photograph at the moment of the composite, we can see there's a large composite. The remaining cusps are thinning out. The ridge is thinning out. We're missing a posterior molar. So this is the terminal tooth in the arch now. I can also see, although it's not very clinically, but I saw in the CBCT that you were showing, looks like the opposing 7 has supra-erupted. So many times in protrusions when patients are functioning or when they're parafunctioning, that can create an interference as well. So we have to look at not just the tooth we're treating, but everything else around that tooth as well onto what might be. And this is just me looking at a photograph and telling you, obviously I don't know the case, Circus, but that's my first opinion, that we need to assess everything around it.
Exactly. And we did. And this is the point I'm trying to make. So when we asked, sometimes, patients always send a few opinions, and dentists want to crown his tooth. But patient said, look, I can understand why. So we went for an opinion, and let's just look at some of the factors that we need to do for this patient. I mean, risk factors. I mean, I like to see, for instance, you look at occlusion, because I didn't give you the other hints, Varun, and I understand that. That's why. I'll look at the patient factors. This is a compliant patient. Is the wishes. That's number one. What she wants to have is her health. Okay. So all these things comes to me by all means, and the other factors is the history of function and parafunction, a history of tooth fracture. And I find that's extremely important to look at this. I look at the whole mouth. There's a tooth missing here. I'd like to know why was that tooth lost. So that's one thing that tells me the history of this. And also, when was the tooth lost and why? Many times in the interview with the patient, normally I don't see the patient in the dental chair. I see them more actually in my consulting room. I just want to know what's going on. And the patient will tell you the whole story. And naturally, furthermore, oral hygiene is important. Her oral hygiene is quite good. Well, we did vital with the testing. The tooth is vital, but when you really press hard on the cusp, you can just feel that the slight pain. And we look at the attachment levels of this tooth. You can see a few issues there, and naturally occlusion, the vertical restorative space, like you explained to me, super eruption. and bone volume density and type of bone loss. So they all come into play because we got to think, do we reorganize this occlusion? It's the first thing comes in my mind. Do we look at confirmative occlusion? Do we need orthodontics? So all these factors come into play. As Varun, you correctly say, we need to think of all the things. Naturally, you can't say this to the patient unless you examine them, but I placed the cone CT because I think it's much better to get some sort of clue ahead of time as which way this goes. So the problem is in this case, so I can point everyone in the right direction, is that it's the 3/6 problem. But also, we'll come later on to look at other teeth because I will show you part of the X-ray. But you can see on the CT scale, I'll give you a bit of a hint, there's a really vertical line on that 3/5. So that doesn't mean it's a root fracture, but there's other tests we have to do and combine them to be able to see if there's other issues in this mouth. Now, when I look at a patient, I look at patient factors. And in a many way, she wasn't worried about, I don't know why this is going, sorry about this, I don't know why there's a line here. She wasn't worried about as much as losing the teeth, but there were other concerns for the patient. Now you might think, why is it the driving force of the patient? Because she lost the 3/7 and nothing was done about it until 3/8 and 2/8 super erupted. But what would you think, by just looking at this picture, would be a concern for the patient? Anybody?
Those popping out masseters will be a worry.
The masseter?
Yeah, when I see them. Of course, he has got a lower lip display, so aesthetic is also something. I don't know what's the color of that tooth, but whether she is worried about that. There's a bit of cant. That means I can see a bit more of a display of the quadrant 2 than quadrant 1. If we're looking at the whole patient, and of course there's a wear pattern there, and I guess she has got the veneers on the top. Am I right? Or
no, there's no veneers. All natural teeth.
Natural teeth. Okay, natural teeth there. Okay. What else? Yeah, that's all I can see from the face first.
It's a tricky question because you know what I'm like. I like to tease everybody, right? I like to annoy people.
Yeah, I know you.
I've been talking to my staff, are you going to tease everyone and annoy them? I said, that's part of the parcel because that's how we learn, don't we? Anyone else? Okay, I want to ask females in the audience, can anyone pick out to see that? What else do you think? This is from a female angle, patient's 45. Here's a hint. What's happening? Anything else you see?
Eyebrow.
I'm so eyebrow.
I was going to do the face reading, but that was.
I had you in mind for this picture, for that one. I knew this. Got you there. Any other takers? Anybody else? No?
Yeah, there's a midline deviation, and she swings to the right, and obviously she's putting a lot of force that way. Okay,
man, I see the point you're making, and I thank you for that. But let me help you. Her main concern is, this is why I said the history of a tooth loss and the effects of a tooth loss, is that on the right side, you can see the dip around the anterior border of the masseter, okay? And that's because there's a molar missing there. I can assure you. When women hit that age and buccal fat starts to disappear slowly, there's a loss of posterior molars. They don't like that. And she knows that if she loses tooth number 3/6, okay, she doesn't want the effect of it. We all clear on that. So you got to understand where your patients are coming from. Don't assume anything. There's something that patients present. I do reconstructive work. Every week I do minimum 2 patients of full mouth, veneers, etc., and reconstructive work. And I can tell you that will be number 1 presenting initiating factor for the patient to come in. So in her mind, it says, I don't like this dip. So when you feel which way this treatment is going to go, you can tell me that initially would be maybe to do some occlusion refinement, so I can reduce the forces and put it on a copper band or metal band on the 3/6 to maintain it, or even crown it, or even place, I'll talk about the treatment in a minute, but one of the early options would be to replace missing 4/6, okay? Because one of the important things is, as Varun said, you want to redistribute forces so that we can at least get a chew on the right side, improve the facial support, and then we can go back and look at the left side within a few months or within a couple of weeks later. We want to proceed with this work as soon as possible. So that was a main concern for her, okay? So that's the main concern for the patient. Now, when we look at, for instance, that's exactly what I was talking to you. So we understood, are we all clear on this? Would you like me, if you're not, please let me know. I'm happy to come back on this. So when we look at a treatment plan and management, control phase. So this control phase means lots of things, and not just saying do things mechanically. We talk to the patient. Patient understands that we know where they're coming from. They're on board with us. They think that we're on the right track. We listen to them. We understand them. Then the diagnostic phase and definite treatment, and naturally you have the protocol. That's the next one. So, and maintenance. So, we know that with the maintenance protocol starts from the initial treatment, not at the end of the treatment. So think about how do we look at this patient? What's his history of fractured tooth and tooth loss? There's considerable supporting bone. Patients on a thin biotype, quite obvious from the chromium CT. I mean, you don't have to do measurements of the gum thickness. The CPO periodont probably disappears. Some of it's quite obvious, but you can if you need to. That's one of the ways, but that's not always accurate. But nevertheless, you can see she had gold inlays. This is the superruption of the 4/1/6. You didn't want that. You didn't want to touch the inlay. She was happy, but she was happy to accept the fact that crown be shorter, but that's fine. We accepted that. But nevertheless, we managed to restore this tooth within 3 months of presentation, give some occlusion contact, and the patient's comfortable with this concept. Now, when we think about the patient's the question we have to ask is what questions would you ask in this patient, in this situation? What would you ask? Let me help you. I want to know, why did tooth number 4/6 fracture? And she will tell you a story. It'll be either I had a filling placed and I was biting one day and suddenly fractured, or I had root canal therapy and was biting until it was fractured, or along those lines. The important part is that I'd like to know also when the tooth was extracted, because the amount of bone resorption tells us the story that in the case she loses other teeth, whereabouts on the left side, where will that final bone go? Okay, and if this is recently, that could be continuous processes as remodeling because then I have to graft the area. But it's been there for a while, then this is stabilized. Maybe you don't need a graft there because maintained without it. Okay, so all these things are really important for me to ask, so I know how I'm planning this case. So back to the tooth on the left side. Now we've managed to fix it on the right side. Now we have 3/6. Let's look at the extension of the X-ray. What do you see here? Do we see any concerns that we may have? Open for questions and suggestions. No suggestions? Let me help you. Well, remember I talked to you about the premolar. So whenever I see a molar is loading, that means there's a positive will be also loading because that's taking a lot of stress, and the positive, especially with the crown, be a lot of stress. The crowns don't wear the same pattern as teeth do, enamel does. So if patients are clenched, there's a lot of forces. I find that clenching patients are far more dangerous in terms of damage to the tooth structure from root fracture point of view than actually bruxing patients. Varun, would that be your experience as well? Clinicians do more damage? You know, there, I'll just continue on that. Okay, so can you see the area here that it's like we're getting what we refer to as a J-curl formation. Can you see that? Okay, now this signifies to me is either infection that's draining from the canal, or there's a possibility of that tooth has been basically the root fracture here. And we all know when we do a root fracture, I mean, is this adequate to say if it's a J-curl, there's a root fracture? I mean, what else would you require? We have a common CT, and I agree with that. But we would probably look at doing a normal assessment, and this is done by my colleague, Dr. Maddy. You go back, you can see an isolated pocket, and that's probably about, probably 9 to 10 millimeter isolated pocket. As you go deeper, so that signifies a single isolated pocket. So there's a good chance you have a root fracture for this patient. And when we look at the CT scan from the lingual side, just you can see the area of the root fracture. That's quite obvious because that doesn't look like a normal premolar like the other one. So it's hard to tell only on common CT by using the actual periodontal measurements as well as your clinical findings. So testing revealed that 3.5 was tended precaution, population occlusion loading, and there's a 10 millimeter pocket associated with this and the distal aspect of it. And also the fact that because symptomatic is most likely we have a vertical root fracture with this patient. So that sort of starts to change the treatment plan because now we have one tooth to replace, which was, I was thinking of 3.5. Now, we need to maintain 3.6. So if it would be easier for the endodontist to say, well, you know what, you're going to lose 3.5. Why don't you just get rid of 3.6 and do 2 implants? Well, that's fine. But remember I said to you about the patient, that the reason for presentation, she doesn't want to lose this tooth, and neither do I, because this tooth is an important tooth to me. But I have to think ahead because whenever you have, teeth with crazed lines and fracture lines, which is quite obvious as here, they always have a guided prognosis. So with the diagnostic testing, let's just look at the video here, and you can see as I'm moving around. Okay, you can see the buccal area. There's a large fracture, right? If I'm moving around and more, and you can see that there's definitely a fracture here somewhere along the line. Okay, and this is why common CTs really help you. You can, open up and look at different directions of this tooth, and that really helps me in your clinical. If you have a common CT, spend some time. There's good programs out there that gives you all the tricks. You can see also the amount of bone that's present in the rest of the teeth and the furcation volume tooth number 3.6. Okay, so we do a guided prognosis, and the patient needs to know this. So where do we start? And what would you do from here? Any suggestions? Nimesh?
Well, as you said, I mean, we have already come to the conclusion that the 3.5 will need to be extracted, and of course, we need to look at the preserving 3.6 as a time being. So, of course, putting a metal band on 3.6 for the time being, that's what I would try with, and consider, of course, removal of 3.5 and let it heal, or because I don't do immediate implant or anything like that. So either it would be just let it heal for some time if she is not overly cautious about having a missing tooth for there for a few months, and then consider maybe a placement of implant at 3.5 and take it from there. But I would still probably, I wasn't sure whether I would consider 3.7 implant in this situation. So I would consider 3.5 implant and just trying to maintain the short arch concept if it was there.
Mm-hmm.
I'm not sure whether that would help on a long run to the patient.
I see what you mean. Well, we've already completed the 4/6 here. My question would be, like you were saying, would you need to plan replacement missing to 3/7 and why? So why would I need? I mean, 3/7 is not always necessary. People should be happy with 6s. And why would I consider replacing missing teeth? In this area, for instance. I mean, why would it be that important for me to do so?
To reduce the load on the 3/6, to be able to preserve the 3/6.
Absolutely, absolutely. That would be number one thing. What else would you think I would do? Consider tooth number 3/7 implant placement.
We have an opposing tooth there, so it's going to be functioning.
Okay, very good. Anything else that comes in my mind? That's very good so far. Really impressed. Thank you. You're on the right track. Is there anything else that you think? We talked about guarded prognosis of tooth number 3/6, didn't we?
So also, in case if we are losing 3/6 in future, maybe we can plan a bridge then from these two implants of 3/5 and 3/7.
Absolutely. So that was the most important thing for the patient, because you explain to the patient you understand from the biopsychosocial point of view that they lost the 4/6 and you replace them. Happy to go ahead, have the tooth number 3/5 and 3/7 errors implanted. Naturally, you got the opposing tooth, and then she understands that we need to adjust that tooth considerably. There's on orthodontics to intrude them, but we managed to get adequate restorative space for this patient. But nevertheless, the plan for replacing tooth number 3/5 and 3/7 is in the future that 3/6 does fail. It does fail. We have an option of replacing it with a bridge work, and that was very important to the patient. Females at age 30, 45, that's an important part of their life, and as a lawyer, as always with the public and presents them. So you have to understand not just from functional point of view, but we also understand from the concept of replacing it with fixed options, because her main also fear has been she never wants to wear dentures. So that was one of the fear, because her father had the same thing and her mother had the same thing, and family was clenches, etc. But it's a sort of way to encourage our patients, and you hold them because they need their psychological support as you're treating them, not just doing things mechanically, that you carefully do and you plan them accordingly. And that's a very good point we just had. Thank you for that. Now, from your point of view, why did I decide initially to place the implant at the same time on tooth number 3/7 and not immediately remove the 3/5? Any all your surgical implant gurus, any reason why I would do the 3/7 first? Just a clinic.
Posterior stop, you're maintaining your vertical height, or?
It's a surgical question. It's a surgical.
Oh, okay. Sorry. Yeah.
Okay, that's okay. That's okay. Why would I do 3/7 first?
Yes. Okay.
See, I don't do implants, but I think it is about more about the axis and the height that you can achieve. If the intra-arch axis is going to be, the space is going to be less, I think, because the size of the premolar implant would depend on what you're choosing on.
呢隻牙有 crack line，呢隻牙都其實都做咗，有 reduction 要剝，你會唔會 put implant on 3/7咧？
Okay, can I just ask?
Why you don't want to put implant here? 剝㗎啦呢啲。
呢隻剝呢隻仲可以做框嘅應該，你會唔會做 implant 3/7咧？點解
What's the opposing?
我先有 tooth。Is in case 呢隻牙死咗，你就做 implant push 嘛？
Okay, can I ask the question? The question is the following. Just hear me out for a second. I'm doing a surgery, okay? And I'm going to do the implant here at the same time, okay? But why I decide to start placing the implant on 3/7 initially before I went to 3/5? Anyone can help me here or not?
Hang on, he said he'll do implant.
Okay. I'll come back to this question later on. Looks like it's a bit confusing. Okay.
Start 3/7 first.
Why? Why
What's
don't you
why?
protect 3/6 first?
3.6 is still required, but why you do 3.7, don't 3.5 first? Why you start with 3.7 first?
Okay.
I don't do it at the same time.
Okay. So, anyway, we replaced the implants and we so got.
You didn't kill the infection.
Take it out and.
Can you mute yourselves, please?
Yeah, you know it's so important to correct
Good job.
clean bone. Can you see or not clean bone?
And okay, let's go next slide. Next slide. Any questions so far? No? No questions?
I mean, you're gonna address Dr. Sarkis about why you chose to put 3.7 first before 3.5. You're gonna address it later on.
I'm happy to address now. Now they're muted, so I'm happy to address this. One of the reasons I would do a 3.7 initially is you can see the implants at an angle because you're super up to 3.7. You have limited access. Okay.
Yeah.
All right. And the patient's a clencher. There's a slight bit of TMD, but she's maintainable. Okay, mainly musculoskeletal, nothing major. So you can see the difficult unfazed here. Okay. Or place the implants. I can't put it more straight. I would like it, but that's all I have. That's the only access I have. If you go back on my planning software, you can just see that, so I'm coming to that one. You can see the angle, all right? That's the only angle I have to actually be able to make a guide and go within reason using piezo surgery to be able to put, there's no, I can put a 2mm initial osteotomy drill to be able to get. It's just too, she can't open the mouth that far. You understand what I'm saying? So the name was that because she's a clencher and she has enough strength left to open wide enough so I can go to the 3.7 side, okay? And then place the implant, give it some rest. And that was the question I was trying to indicate. So sometimes you have to picture patients in a way that what's comfortable for them. And the other thing is the surgical side. Okay, if there's any bleeding, etc., I can control this because there's a bleeding on the right side that will make it impossible to work on the left side, distally. Is that clear? So planning your surgery is extremely important, okay? And naturally, this was a 3.7 was a keyhole surgery, but we did open up a little flap to make sure that I was in the right position, and we verified it. Someone's now put a pin there, guide pin there. That's a guide pin here. I'm not quite sure I'm in the right position further back in the mouth. It's very simple to just put a patient, take a micro cone beam CT. You know exactly where you are. You verify your position. You're going to put in the most accurate way of doing implant. You're using guided surgery in an anatomically constricted area with lots of neurovascular vessels around you. So thinking ahead of time and planning your surgery, not just simply just doing, if you're referring your surgery, I understand, but your periodontist or surgeon needs to think of that. And you have to provide the guidance. So this is all guided. So I know exactly where my crown is. I know where my emergence profile is. I know exactly where my occlusion is. It's all been planned with precision. Now, guide can be up to, 1mm to 7mm totally in the wrong place. That's why you cannot totally trust surgical guides. What really confuses me and surprises me is dentists who rely on third parties who are non-dentists or not even qualified in that area. They actually plan in surgical templates for them. It's crazy, but this is happening more and more as I'm seeing a lot of these cases coming in the surgery. So that's the reason. So one of the other important things that we discuss is, the implants are integrated. We're about to restore this patient. So I like to desensitize this tooth. The trauma that you put the tooth when you do a crown, especially with cracked teeth, can actually induce irreversible pulpitis. And when you open that tooth up, because all the stresses within the tooth, it can actually open up the cracks. That's the end of the tooth, and you lose the tooth. So for this patient, it was copious irrigation, as minimal as I could to be able to gain. And naturally, you know how much I love my gold margins because they have 2mm gold margins subgingially that goes and grabs that root there. And I ask the technician specifically, I want, like, you know, maximum 40 microns clearance on top, around 30 microns on the bottom. So this is all gilded. Now, I haven't showed you the actual copper plated dies here, but I will sit down, take an X-ray, and make sure I get all the margin up perfect that seals this tooth. See, my concern is that when people do, you know, zirconia crowns and root therapy teeth, because they don't sort of wear same rate. With the metal ceramic, with a feldspathic porcelain that's over there, that actually gives you a good wear. You know, it's quite a good wear of the opposing teeth. And naturally, you need to refine the occlusion, because they don't wear the same rate as the rest of the teeth. And you refine the occlusion. You got metal feldspathic porcelain here on a PFM or metal ceramic crown. You have a zirconia. You have another zirconia. Fully coated. The problem is that the dissimilar materials, the wear rate is so different. So if you understand that regular maintenance, fine tuning is an important part of your armamentarium. And again, any cracked tooth is a guided prognosis. You know, any cracked tooth is a guided prognosis. You know, you need to understand these little things and explain to the patient that there's any problems, you know, and how do we have a prescription of this teeth. We'll talk about occlusion prescription soon. But the name of the game is, I'm just showing laboratory work, is to be able to create, you know, have 30 micron margins that goes and grabs this tooth, especially in here where you can see it just going to the bifurcation areas. And I'm never afraid of violating the crown, the biologic width at all. So from here, you can see that 3-7, I have enough room to build. Basically, I have flat occlusion. Point contacts could be in the center, only on the maximal clench. So these two implants can take load, but that one can't. Okay, this is just touch of point contact. And sideways excursive, no contact, no inclines on the cusps. Okay, this is your occlusion prescription, because you need to do that to be able to reduce the force. It's taking a load, that's taking a load, that's taking a slight load, but this one hardly any. Okay, it's almost clearance. And flat occlusion is very important part of prescription. I don't want to see this, you know, P.K. Thomas's big, nice, beautiful cusp, etc. It doesn't mean anything to me. Okay, so I'm restoring a compromised tooth. Look at how much bone this one has buccal in. Okay, and it comes with premolar. Okay, this is also, that should be a large one as well. It's the second premolar. You look at the molar should be quite big. It's lost. So small occlusal table. I'm trying to reduce, give it more occlusal, room, because it's minimal. It's restricted interarch, restore the space, but nevertheless be able to, if this goes, we can join across, like our previous colleague said. So we did restore this tooth. You know, we did went ahead, and you can see how well sealed margins are, different angles, and you can see how the metal ceramic crown just grabs this tooth. Okay. Okay, this is a long knife edge. Okay, you can never get a fit that good in any of the restorations. So we all know it. Varun, if you're there, you can confirm what I'm saying, but we all know that the fit of this restoration is just second to none. Okay, I can show you. If you have to try to get this in zirconia or Emax, you have to cut a lot of tooth structure, and I compromise the core. In this way, I'm grabbing into the bifurcation areas, and that's not a problem. So this tooth is now under loading conditions with a normal width of the periodontal. Still, it's you can see that we'll probably recess a few years later. There's a bit of bifurcation involvement, but the patient maintains all the hygiene, and I'm quite happy with this one. Looking at the laboratory, just to show you, you can see the angulation. Okay, and that's as planned, because the opposing tooth is right here. So it is a complex work, and how do we plan this work to get a successful outcome is basically for patients to understand the difficulties faced. There's no way I can put the implant this direction, but we all know that you can have an angled implant that carries the occlusion weight very well, and a small platform, occlusion platform for this patient to reduce forces. But if you ever lose this tooth, hope I don't, we can always go across and bridge across. That's not for fail-safe position for this patient. Any questions so far from the laboratory before I move on? Any questions?
There are a few questions on the chat. Have you addressed all of them?
I haven't, because I can't. I thought Natasha was going to address them for me. Are you there, Natasha?
Yeah. Ravi is asking, is there a root pathology on 36?
The root pathology here. This is vital. Okay, this is vital. The endodontist has tested the tooth and is happy for me to crown this. So I have had a second opinion on that. Just because you see a little area here doesn't mean that it's just been loading for a long time. Okay. Patient has no symptoms. There's no pain. And it's very hard to test now under a crown. The vitality is happy with this. Okay, so we maintain this tooth and everything's normal. I'll take regular exercise every 6 months and look at that case. But I'm not going to try to jump in and do root canal therapy on this patient. At the moment, I prefer not to, because even the donor said just maintain as you can, but the patient's aware of it. We know when we open this up, the root therapy, all the stress will just open up, the tooth will just break. Okay, so we'll wait and see, give it time, and let nature take care of it. Good question, Robbie. Here's our crown.
Dr. Circus, there's a question. Is there a root pathology on 3/6?
No.
You just addressed that question already.
Oh, okay. That's fine. Sorry.
Yeah.
My thing just dropped out.
That's okay. I would not even go there at the moment because we want to hang on what we have. This has been tested with questionable and guarded prognosis. I will take another X-ray another 12 months time and make a decision. The patient's aware of it. They have to understand that. Okay. Any other questions on that? Is any? I'm sorry, I'm not reading the questions because I'm under the pressure of my.
Circus.
Yep.
Great presentation, and I agree with everything that you've done, and I would have treated the patient something very closely myself. So I don't think from a treatment philosophy point there is much that I would change. Now I'm going to play a little bit devil's advocate, and I was hoping someone would ask this question. What is your opinion on people when you have a tooth with, let's say, in this situation, you had an MO composite with weakened cusp and a marginal fracture on the distal ridge. Although the tooth had frication, would you be able to treat this tooth with, let's say, a more form of conservative bonded Emax onlay, where you could keep all your margins quite away from that frication, rather than doing a full crown where we're going subgingival?
Good question. My biggest concern is in this particular area, and I like the question by everyone, is that I cannot tell how far is the crack propagating. Okay, and if I go ahead and do a conservative onlay and be supragingival area, that's fine. But one reason I find that if I, in this, especially with frication involvement, doing the preparations at that level of gold margin, we're actually grabbing the whole tooth. And it allows me to control the occlusion, and not only that, I'm going past any foreseeable crack or craze lines that I have. That would be my answer for that. The other thing is that if I go ahead and do the inlays, I'm sort of opening up again, opening up the cast deflection. The cast might deflect immensely. And that will sort of, I want to be able to cover this as soon as I can, basically, because of the past experience the patient had. The fact you got a history of fractured teeth. Placing an Emax onlay, that would be the second option. But I would say at this stage, the metal ceramic crown, full coverage, and going subgingivally, because the cracks do travel quite deep. I couldn't show you the picture of the distal of this area, because right subgingivally, I need to sort of pick that up and give it the best thing I can. That's all.
Yeah. No.
There's also another comment, and that's us saying the intercloser height appears very low in 3/7.
Yes. Is that a problem?
I think it was just a comment from someone.
Okay. Well, of course I understand that, but don't forget, occlusive is super erupt into the side, into the area. Okay, it's super erupt into the area, and that's quite low. So we can adjust this accordingly. We can adjust it slowly. Patient has on orthodontics, and now we could have made a little temporary crown and added composite on temporary crown and try to intrude the tooth. That's also a possibility. Okay. That was all discussed with the patient. So to me, this being low from the functional point of view, it doesn't matter because there's no occlusion interference on protrusive or any excessive movements. And I will show you that later. Have I answered that question?
I think we're good.
Okay. So we're at this stage. We talked about laboratory.
Oh, actually, Dr. Circus, they're saying, I just thought it had to be a minimum of 5 millimeters.
Yes. Okay. Is this minimum of 5 millimeters here? I think more than that. That's a componentry, and sometimes we need occlusal support. For me, if we lost tooth number 36, not to replace across the bridgeway, to me it really doesn't matter the distal one, as long as I have my occlusal prescription in the contact pattern in the most favorable physiologic occlusion that we can possibly achieve for the patient. So just because this is not an occlusal platform because of the opposing tooth, I don't think that's a big hindrance because if I keep grinding the opposing tooth, you can cause sensitivity. Okay, that will create other problems. So within a reason, okay, so within reason, see what we think is what's ideal from our mindset is not necessarily ideal for the patient. So you have to find the solution that what's best for the patient and from the clinical point of view to achieve a practical and favorable outcome and for this patient.
There's also another comment from Dr. Ravi who says, considering there is an abscess on 3-5, how long should you leave before placing an implant? Should you wait until complete reformation?
Now, 3-5, we place immediate implants and grafted, which is cleaner. That's immediately placed and grafted. It's not an issue. It's 3-6. He's talking about 3-6. Ravi, can you ask the question again, please, Ravi?
Yeah, I thought, should you wait until the complete bone reformation, because that looks like there's a radiolucent area, and would that matter the longevity of 3-5 implant?
No, because it's a complete graft there. So I will clean that out and graft it. There's a 3-wall defect, or 3 or 4-wall defect almost. So that area there is very minimal here. So we build up the whole bone and we do it at the same time. So to me, that's not a problem, Ravi. I've done a lot of that. But if you're doing implants initially, yes, I recommend that you take that tooth out, you let it heal, then you come back and regraft and build that up. That's a type 3 treatment option, and you can do that. That's fine. But I feel quite comfortable having done lots of them. So I do apologize of my initially. I mean, that may not be orthodox, but it works quite well. Most of the implants are replaced by immediate. And I have the same situation with molars. I can place immediate molars. The failure rate is the same sort of failure rate as another implant because it's just how you deal with the bone is important. How you need to respect the bone when you're doing implant surgery. In that way, how you place the implant, the position to minimize the bone dehiscency, buccally, then you're able to restore that accordingly. You remove the infection because it's been there for a long time. If it's acute infection, actually you can't do implants. But it's chronically draining sinus. In many of the immediate treatments, especially in the upper anterior aesthetic zone, they're all immediates. So you're away from the area and you clean that area, you're grafting it. So that's been around for a long time now.
Thanks.
Is that okay?
Yep, thanks.
The question is, that everyone's should be asking is, and I'm sure Varun has pointed that, is what is your occlusal prescription and your contact pattern? I mean, you can see it, there's a dipping, and I agree. Of course I can see it. I mean, I created it. I can see it, and I agree. But what else do we have? Let's look at our laboratory work. We have adequate room to have a prosthetic components that can fit in there. So, and the patients are aware of later on, we can add some composites on the screw access hole and intrude the maxillary molar if you need to. And if the patient's happy, that's fine. The options are there. But I'd rather have a zirconia crown here As a long-term temporary, that's the case, intrude the posterior molar rather than through some composite of the PMA, polymethacrylate crown that keeps fracturing all the time. So I could say, well, I regard this as a long-term provisional crown, and that's the type of patient management. And later on, we have the whole area, we have all scans, we can just make a whole new crown if you want to intrude the tooth. But that's what the patient's happy about. And when you think about it, look at the occlusion of this patient. I'm sorry about the quality of the picture because most of the time we take photos in a hurry. But nevertheless, the whole idea of the treatment plan is to reduce excursive lateral forces on your restoration, have a point contact on the implants and reduce the contact on the molar, and that should be a continued process. You can see as we go lateral, there's a total clearance, okay? And at the same time, as you go in a different angle here, there's a total clearance on both sides. So when you plan your cases and you know, you put things on the articulator, okay, and you have a look at it. Well, sometimes the best articulator is the actual mouth. So do your retraction, take your Samsung camera, like this one here, and get the patient to do those movements. That tells you in dynamic format the scheme, the prescription of the occlusion, where you can place it so that there's minimal trauma, minimal interference with the patient's existing, you know, occlusal pattern. And this is what you have to do. So occlusion prescription, go to the side, it's canine guidance here. It's not touching on the molars at all. I can tell it's a canine guidance, total clearance, okay. And this way, what we did is we're saving the molar. That was the whole essence of today's question, is we're saving the molar, okay. And she's happy because it provides a good facial support. Now, I'm not sure what will happen in the future, but she's very comfortable that if she does ever lose the molar, we'll be able to graft this side to reduce further resorption and make it bridge. We will put immediately, make an immediate temporary bridge or immediate zirconia type of temporary bridge at the same time while this tooth being removed. So patient will have the tooth removed, the socket is grafted, and walk out as if there's no missing tooth in the same position of this molar. We can guide it, guide the healing pattern here to provide a nice, you know, cheek support that woman of 45 desires. And this is about diagnosis and planning. And again, I'm happy to invite any comments, but on the treatment planning, because the most important thing is you know, you got to plan for results and not for procedures. Remember, I spoke to you before about the important part of the college that we teach is look at all angles, and we welcome all the questions, all the even the ones that didn't like asking. That's what it's all about. Learning is about taking time to look at the problem and approach the problem from a problem-solving point of view, but also helping your patients. Because, you know, as a specialist, I solve problems every day, and you as a general practitioner, you solve problems every day. You've probably seen this brochure. All the brochure is I've taken the photography, and you know, all the work is done by us. There's no Photoshop. There's no nothing. It's, as you see, the most important. You notice the photography here. One of my assistants, Vivek, took this photo because I've been trained how to take a photo. And sometimes we invite photographers to come in and teach dental how to do photography. I think the clinician should be able to take your own photos in your clinical cases, because if I would know that anyone else but me that has taken that intraoral image or extraoral image, because I look at things a certain way. And in a college where you do your diploma, we teach you what to look for. You know, the old saying, which I had mentioned this 20 years ago when I was writing King's College's the modules. What the eye cannot see, the mind cannot recognize. You have to see it for your eye, because the best camera is your eye. If you see it, you understand the problem, then you can take the photos accordingly. And that's so very important to have. You know, we've selected some very good practitioners in the college to learn, to teach, and they be learning as well and teaching as well. I've been learning from all of the colleagues in the program as well as all of the students. But we're going to go to the basics because I think the basics been missing in most of the teaching. You know, I often wonder when people talk about, you know, doing things digitally. I can assure you that if you learn about direct composite mock-up, you're doing real smart design for a picture here, and the patient can see that you are the artist, and you're able to produce in their mouth. Can you imagine the confidence that you build with the patient during that process of 1.5 to 2 hours that you're doing this diagnostics? And they feel they're in the safe hands. But if somehow your technician brings, you know, that the mock-up is done, you're going to try it to see how it works, etc. I don't think, to me, as an experienced clinician, the impact isn't there because you need to understand how to diagnose the facial features, you know, how the mouth comes together, dynamics of the facial expression, the dynamics of the speech, and you know, the whole jaw movements, how to create. I can do lots of things that I know that will work for the patients. And again, people say, look, I don't want to learn about diagnosis and photography. I want to triple. I just want to go occlusion. Give me occlusion. Give it to me now. I want it now. Hang on a minute. That's what I'm talking about. There's a lot of things that people say, I don't really, occlusion doesn't make sense to me. It's a simple stuff, occlusion. But because it doesn't make sense, I believe it has been taught properly. Okay. We're going to talk about how do we do minimal implantation porcelain technology veneers, how to minimal preps. This patient had minimal prep veneers. And if you get the perspectives, you can see it. This is minimal prep veneers. We had to replace the old porcelain work for this patient, okay, doing reconstructive work. We need dentures. I can't understand why the prosthetists have taken on the dentures, but if you do know how to make good dentures, how to construct good full and partial dentures, your practice will flourish because population is getting older. So there's going to be need always a good dentures, and you know, and everyone wants to do implants. You know, there's a disease out there. There's a disease how to drill a bone and put the implant in. That's fine. To me, that's prosthodontics. It's not implant surgery. Yes, I'm an implantologist. That's just prosthodontics. It's part of the whole treatment outline. Okay, how to plan is the key. Not how to drill, it's how to plan. Okay, how to plan is the key. How to incorporate this whole thing into dental facial aesthetics. How to make things look really, really good. What I don't understand is, you know, when people tell me they can, you know, they do all this, there's advertising. I saw that $7,000 for full mouth IMAX veneers. We're selling dentistry too cheap. I mean, it shouldn't be. I mean, you know, you all know that my fee for this work will be many, many times over because I know and I value my work. And when we teach you at the college, we're going to teach you how to value your work because, you know, your time you spend, your education you spend, how we teach you how to talk to the patients, how to really understand which way to go in teaching those patients, how to own their problems. I just want to show you this video. I'm going to play this video for a second. I want you to look at this.
Good morning. How are you? I'm well.
We're doing diagnostic mock-up. It's a two-way. It's part of the course on Sunday.
What would you like me to do? I've never liked my butterfly teeth at the front there, and over time I've brought my teeth down. I have chips, which my children laugh at when I smile or show my teeth. Right. So I'd finally like to have my teeth straight across the top, and actually have a nice smile.
Now, I love what I do, okay? I love what I do. So this is direct mock-up. We keep going. And there's pre-COVID time, so I wasn't wearing face masks, but the issue is, you know, we do mock-up and we build up. And, you know, that's a direct mock-up, okay? Just quickly, it takes about an hour and a half. And we teach you how to do this.
That is amazing.
So you're the artist, okay? You think about which is better. What I just did for this patient, the mock-up to diagnostic, this whole thing's going to come off. Or you go ahead, some look at a digital smart design. I could never understand. We teach you how to do this. So with digital smart design, you're going to make the technicians wealthy, but this way you will take that money home. Okay, so the issue is when we talk about doing tooth-free or any other treatment, understanding that it takes time to diagnose. It really takes time to think about which is the best treatment options for your patients. And from the treatment point of view, I can show you about more than 30% of my practice income comes from composite reconstructions. They're simple. They're less traumatic. It's easy to repair them. You can maintain the longevity for a long time. Okay. Now this patient or the patient previously, you know, they can't afford $40,000 of dentistry. It's just not going to happen. But if you do the diagnostics and you do the composite work on them, then maybe a few years down the track, they realize that you were right, because they do wear, and so that's porcelain. But in a way, the aim is to treat all patients from all walks of life, and the treatment that you provide that will be within their budget. And that's what good dentistry does. Okay, you know, you can do full mouth reconstruction with composite, you can do simple restoration with composite, but the aim is to be able to help our patients. So I really thank you for that today. And if there's any questions you have, please ask me.
Circus, would you ever consider, let's say we just replace 3.5, put a crown on 3.6, not to restore 3.7, and if you lose a 3.6 in the future, you can just place an implant at 3.6 and just keep the arch short.
Replace the implant at 3.7.
No, leave the 3.7 as it is, not to do anything at 3.7 and just keep the short arch.
Hang on. You're saying 3.7 is an implant. I'll place the implant there, right?
Yeah, no. In case, so if I go back at the very beginning and not to put anything at 3.7,
and
just to consider 3.5 exo, place an implant at 3.5, place a crown on 3.6, and see how she functions. And if anything happens to the 3.6 with the loading, or if there's a failure, we can just extract and replace 3.6 with implant instead of actually placing a 3.7.
So don't do an implant at 3.7. Is that what you're saying? Just put it here.
Yeah.
All right, let me ask you the question differently. Okay.
Yeah.
I can understand why you're saying that. See, my point of view is that something's going to happen with this 3.6. Okay. That's just my experience. Now, what's my contingency planning? What's my fallback position? Okay. So my fallback position would be if I don't put this tooth in the right bite, and I need to reduce the load on this. So part of the saving protocol is to reduce the load on 3.6. Okay, so by placing crown here and crown here on the implants, I can maintain the occlusion with minimal contact fellow occlusion on 3.6. So I'm reducing load already. So I'm improving the longevity of 3.6.
Okay.
Okay, so if I don't do this, all I'll do is 3.6 will be loading. Eventually it will go. And if it does go, okay, what's my fallback? She doesn't want to be a gap, doesn't want to face the drop. Remember the first thing she came for? That was her main goal. Okay. I mean,
okay.
That was the point. Any other questions you have?
No, that's all good.
Dr. Circus, I just like to express that I'm actually resonating to your choice to save the 3.6, because in our clinic, there are people that really do not want to extract any of the remaining teeth. They could have a history, a story that they feel really sad, and they feel like they fail themselves when they just let go a body part, like a tooth is a part of them. So to be able to hang on to that 3.6 for however long that's possible means something to them. And for this particular lady, we happen to have somebody very similar to her, that to the dentist, we might just want to say, oh, wow, you know, this is a case that you just have to do a full mouth reconstruction, also everywhere, get that perfect occlusion, get it here and there. The problem is that that patient didn't feel perfect to start with. And she actually feel very bad about her current condition. And in able to actually encourage her by saving the 3.6, really build that trust and the rapport with her. And she feel like she did something right to actually save the tooth by finding the right dentist who actually listen to her. And I know the result is not the textbook ideal you know, the balanced, you know, the perfect line of the smile line, the curved speed, the occlusal plane. But sometimes what we are doing is not really about satisfy our viewpoint of the perfection. It is really to really treat that patient, and that patient will be your client for life. And being able to actually save that 3/6, even though you might end up doing a root canal through the crown, even though that you might lose the tooth at the end, patient was ready for it because she already lost the other tooth. But having that dough on that tooth to save it mean a lot to her. And when you actually do that, whatever you provide her later, she's gonna take in, and she might turn into a full mouth reconstruction at the end. But every step that she follow with a complete trust in you. So thank you very much for sharing this.
Thank you very much for actually bringing that important point of view that we are not treating the mouth, we are treating the patient. And the patient understands that you have empathy, trying to hang on to the tooth with an understanding that we have a guided prognosis and the rationale behind your treatment planning, that you are thinking this way. You see, sometimes when things go wrong, I read my colleagues and say, look, I'm really sorry to see that you've got a patient here, but let me know, what was the rationale behind your treatment planning? And they said, look, we really try to hang on to this tooth. I can see that this person, this colleague, is empathetic. You know, if people have empathy, you know, it fixes up 99% of the thing. Seriously, 99%. If you have empathy, empathy, in my opinion, is everything. Because you know that's sort of missing in the society at the moment. You know, and the important thing is that, you know, we knew the problem she came with. She lost the tooth on the right side. Her face did. Her 45 years of age. She doesn't want to age. She wants to stay youthful. Okay. So from that point of view, okay, this is a center tooth for her in terms of her life, her youthfulness, because we all want to look youthful. We want to cling on to the past. You know, when you're 45, nothing. Wait till you get my age. You still want to look good. That makes sense? That's important. So it is important to understand where the patients are coming from. For instance, I see patients for a second opinion. We're going to a dentist who's done an all-on-4 course last week, and suddenly every person that walks in the door on Monday is an all-on-4 candidate. Okay, and it says, well, my teeth are perfect. He wants to take them out, put it all-on-4, because he's been told that you have to fit the treatment to the patient. Okay, or patient to the treatment, not the treatment to the patient. You have to pay the patient to the treatment. And lower this patient have all these major tooth extractions and implants placed. When implants start to fail, okay, and they're done at the age of 45 or 50, now they're living about 60, then their whole health changes. They're, you know, suddenly they're no longer the same health as they used to be. You start losing bone, risk factors, medications, polypharmacy, and what happens then? You got no bone. Okay, where do you go from here? See, we have to think. Patients have to know the situation. They have to know that you explain to them. I many times I bring them once, bring them twice, bring them 3 times to consultation until they are mentally ready, until they really understand what I'm talking about. Because if they don't, I'm happy to give them their records and say, you need to see somebody else because you don't understand what I'm trying to tell you. Then I don't know that problem. Okay. See, complication, when people say the success rate of the implant on the anterior zone immediate place is 95%. Okay. And you say, oh, really? Let me look at the article. And you find that in that 10-year protocol, only 1%, or maybe out of the 100, only 5 patients went all the way to the 10 years. But the other patients were added onto the study. So how true is that in terms of 95%? So if you say to them, well, what about the other 5%? Oh, they failed. All right, the faster. But what about the static failure? What are you talking about static? Implants hanging on? No. What are the gum recession around the implants? What about bone remodeling around the implants? Okay. Well, what about it starts thinning and the patient got a high smile line, suddenly gray, the black hair starts appearing after 5 years? Oh, no, they didn't think of that. Of course you didn't think of that. But I do. I tell the patient, this is what happens. This is what we get to. This is how we fix the problem. So the patient understands. First, a typical example is replacing the lateral incisor. The #1 first protocol replacing the lateral incisor is Maryland's Bridger. The client Bridger, Bonner Bridges. Okay, we got 18 studies by a very good colleague from Germany. Okay, and we need to understand that sometimes implants not the only answer. You need to preserve teeth, to preserve bone. Implants don't preserve bone. How many times do I get, I'll better for implants, otherwise bone will go away? No, bone will go away. Bone doesn't give a, 2 cents worth about whether you have implant or not. Bone goes where it wants to go. That's genetically programmed. Okay, we should understand. That's why I mentioned to you on the right side. I said, I want to see this a recent extraction or a long time ago, because I know where the bone is. So in that way, I know exactly where if we lose 3/6, where the bone will go. It's only a matter of time. See, I have to understand the aging patterns, bone resorption patterns, okay? And many other things come into play. That's why in the 2-year program, you learn how to think, okay? Not to think empirically, like this recipe-based, but to actually think in terms of case-by-case assessment. And what's the evidence? What's the clinical evidence? What's the big cohort evidence? Someone says, oh, it's 95% success rate. Hang on a minute. Whose research are you reading from? Is it yours or somebody else's? And was the research done in private practice, at least that belongs, at least can be replicated to you or not? What is your success rate in your practice? I tell colleagues, like, how many implants have you done? People say, I've done 500, I've done 1,000. Well, I've done thousands of crowns. Fair enough. Fair enough. Okay, I remember I was in Moscow once lecturing, and I was talking about diagnosis and treatment planning of fractured teeth, which is my favorite area. And someone says, you talk about diagnosis and treatment planning. I want solutions. I've done thousands of times. And he stood me up in a lecture. And I said, who's the person? He go up, so thank you for your question, but I've got a question to ask you. He said, well, what is it? He was really angry, by the way. I could see he was frustrated with having these problems. I said, did it ever occur to you that you could have done the same procedure 1,000 times wrong? He thought about it, says, that's a good answer. And the thing is that the college that we have, that we teach, is about giving you the right experience, the right mentorship. You become part of a very exclusive club that allows you to exchange ideas, get solutions, and learn, because I learn from you. That's what it's all about. I had a great discussion. I really enjoyed it. I want to thank every one of you for being with me. And Kathy, Nimesh, Varun, thank you very much for being part of this discussion. Happy to have any questions if you have. Natasha, any more questions?
There's none on the chat. They're just thank yous.
Thank you very much, all. Thank you. Okay, so I will say goodbye to you. Now, next seminar is going to be very great. We have Mehdi and we have also Derek Mahoney discuss all those interesting cases. Varun, love to have your input as well. It's your alley, talking about bonded Maryland's bridges and resolving some high anesthetic issues. So that'll be a good case of discussion. Thank you all. Look forward to seeing you in 2 weeks. And if you can make it this Sunday seminar, please do. Love to see you on Sunday. It's all in the pipeline. You can ask Natasha, she can send you all stuff. Thank you all.
Thank you, Doctor.
Thank you.